Okay. Shall I admit everyone?
Yeah, let's start.
Professor Ashraf is also here from Pakistan.
Ashraf and
Ashraf
also
Nizami.
from Malaysia, Raju, he comes every time I do.
Yeah, so I'm admitting everyone, Dr. Russell,
Right.
and if you want, you can start your recording as well.
But you're doing it, no?
Yeah, I'm doing it.
All right, we have Madalena. Okay, a very good morning to our friends from the United States, our colleagues in Brazil and Argentina, and good afternoon to Madalena, to the Portuguese and English colleagues here, and then to the from Africa and sorry, East Africa and Israel. A very good afternoon and good evening into India, and good evening to Malaysia and Hong Kong, China, and of course this from Australia. Very good night to all of you in Australia. I'm delighted to welcome you to the 17th webinar in the UNESCO Chairs series that has been going for a period of time now. And it is great. I'm greatly honored to have our presenter, Dr. K.K. Agarwal, who is well known. He is the president of the Confederation of Asia and Medical Associations of Asia and Oceania, which is where Australia, New Zealand, and so forth come along in that region. And I'm delighted to also welcome Professor Joseph Thornton, who is from Florida. He's from the Veteran Affairs Hospital and the University of Florida. He's going to chair this session and offer his comments. He's also the head of the bioethics program at the University of Florida. And we have, of course, Dr. Mary, my co-chair, Professor Mary Matthew, who co-chairs this program, and Colonel Doric D'Souza, who is going to be the moderator and looking after all of you on the chat box, because today's presentation on the ethical issues in managing the COVID patient is very important. And Dr. K.K. Agarwal has been, every week he has a meeting with all the Asian presidents and has been doing a wonderful job in this. I'm delighted that we have an international audience here from around the world. And I want to, this is part of the job, part of what the UNESCO chair has been, and the Department of Education has been endeavoring to bring solidarity to this pandemic, which all of us together are facing. So this symbolizes that. So with this, I'm now going to, after welcoming all of you, I also want to acknowledge the international committee that has put this together. And we have, well, Professor Joe Thornton is one of them. We have Dr. Animesh Jain, Professor Animesh Jain, Professor Gerard Fortwinkel from Hanover. They're all here, and Professor Baroness Elora Finlay, who has asked, is away somewhere and not able to attend. Professor Madalena Patrico, I see here from Portugal, and who else is there from and Principality.
Dr. Geeta Lakshmi is there.
Yeah, Dr. Geeta
Madam
Lakshmi
Vatsala is also there. Yes.
So all these, I welcome you, all the committee, and and acknowledge your presence. Now, can I hand it over to Professor Mary Matthew on behalf of the committee and the program to talk to you?
Yes. Thank you, Dr. Russell, and good morning, good afternoon, good evening to all our participants. Today's webinar is probably a culmination of what we've been talking about this pandemic. And we have a very eminent speaker today, Dr. K.K. Agarwal. And if anyone knows anything about COVID, it is Dr. Agarwal. He's the go-to person, and he's been updating the whole country regarding what is happening, and especially the management. And that is why it is important. I'm very happy to see all of you joining in. And this time we'll give all of you an opportunity to ask the questions. You can also put it on the chat box, but this probably would be one of the live question answer sessions that we are planning to have. And thank you on behalf of the Indian program of the UNESCO chair. I welcome all of you. And I now welcome Dr. Derek D'Souza, who's going to be the moderator. And Derek, over to you.
Thank you, ma'am, for that introduction and for laying the groundwork for us. I'm not going to stand in the way of you and the rest of the session. Just a couple of quick requests from my side. Other than the speaker and the main participants, may I request each and every one of you to kindly mute your microphones as well as switch off your video. That helps us with the bandwidth and will improve the quality of the voice as well as the transmission that you are able to see, since we have a large number of participants online. You are free to type in your questions into the chat box, and we will collate them at the end, and along with Professor Joe, we'll be putting them to Professor Agarwal, who I'm sure will take them one at a time. And if possible, we'll try and get you on screen as well. So towards the end of the presentation, please be ready, and we may start your video with a request to you, and you can ask your questions live to Professor Agarwal. So with that request, I hand you over to Professor Joe Thornton, who's the chair of today's session, to take us ahead, sir. Dr. Joe.
Okay, well, thank you all. Thank you, Doctors Russell D'Souza, Dr. Mary Matthew, and Dr. Derek D'Souza. I'm honored to be able to introduce the speaker today. Dr. K.K. Agarwal is the president of the Medical Associations of Asia and Oceania. He's past president of the Indian Medical Association and president of the Hump Foundation in India, and eminent expert and speaker on our topic today. So thank you, Dr. Agarwal.
Thank you, Dr. Joseph Thornton, the chair, Derek, Mary, and Dr. Russell, for asking me to share some of the views. But before I talk about the ethics, I would like to talk about the paradigm shift which has happened in our understanding in the concept of COVID, starting from March to July. Ideally, it should have been January to July, but 31st of January was the first case we saw in India. And the 18th of January, we were in Myanmar talking about Corona. And then February and March. So I'm basically talking about paradigm shift in understanding the concept of COVID, which actually started from March to July. From February and March, the thinking was the same. We said this is a mysterious virus. That means way back in December 31st, people started talking about a mysterious pneumonia in Wuhan. Then people started talking about, is it actually a virus or is it a bacteria-like symptoms? And today we know this is predictably unpredictable virus. From a predictable virus, now the paradigm shift is, it is a predictably unpredictable virus. Why? It causes no joint involvement, it involves no lymph nodes, it causes no hoarseness of voice like other respiratory illnesses. This is a virus which is predominantly inflammatory in origin. We don't have any other virus in the history which causes so much inflammation as this. This is a thromboinflammatory virus because it causes thrombosis quite early in the course. It causes hypercoagulation. There was a time we were talking about watch this patient for 30 days, 40 days, 50 days. Today we are talking about watch only day 3, 4, 5, and 6. Even these 4 days you can pick up early happy hypoxia, early desaturation, early 6-minute walk test, exertional hypoxia, exertional breathlessness, exertional cough. We know that we have diagnosed the disease early and mortality can be reduced. We all were talking about from macro droplets to now micro droplets. That means we are now talking about a partial airborne. So therefore, we are now talking about a ventilated versus ill-ventilated places. And now we are talking about a common toilet, a common TV, a common kitchen, and a common place to sit is an important cause of infection, specifically in crowded countries like India, Bangladesh, and Pakistan, where the density of the people is very, very, very high. There was a time we were talking about surface to human transmission. Now we are talking about that may not be that important because in the heat, we have not seen in summer the virus disappearing, and we have not seen the virus increasing with humidity. We all started with no masking in public, and now we are talking about masking in public. Then we shifted from simple mask to N95 mask, and now we are talking about masking with valve in the public and masking without valve in the healthcare. And now we are talking about masking at home. There was a time no masking in the public, only masking when you go out. When we are now talking about masking at home, we started with a 3 feet distancing precaution. We shifted to 6 feet. Now we are shifting to 9 feet. Once we know this is micro droplets, we shifted from a lockdown to personal lockdown that I need to prevent myself. Though it is my duty to protect myself, and therefore I need an area of 6 by 6, which is virus free. We started with a mortality of 30% with MERS. We started comparing it with Spanish flu, which had a 10% mortality. We started comparing it with SARS-1, which had 10% mortality, MERS 30% mortality. And then we started talking about 3% mortality. But today, at least in the Asian countries, we know the mortality is 0.3%. Kerala in India, Delhi in India, and Sri Lanka as a country, we have seen it is achievable to have a mortality of 0.3%. The serosurveillance of Delhi a couple of days back was 23.8%, and that gives us a mortality of 0.3%. So therefore, now all our ethical and discussions will change depending upon the paradigm shift. We are shifting from institutional care to home care as a fundamental right, though all the countries are still not following home care. Bangladesh is still not following. Even in India, many states are not following home care. No treatment available was how we started, that this is a novel virus, no treatment is available. Now we know that treatment is available for each and every patient, depending upon what complications he has. If he's thrombogenic, we have treatment. If he's cytokine crisis, IL-6, we have drugs. Antiviral drugs we have, and anti-inflammatory drugs we have. Initially, we said a mandatory ventilation. In fact, the whole ethical problem started with Italy and about triaging, whom to triage, whom not to triage. Because in Italy, Iran, and in New York, people started talking about that ventilators are not available. In India, in February and March, we were collecting ventilators. We requested US to donate us 20,000 ventilators. And today we know that 63% of ventilator beds in Delhi are lying vacant. So we shifted our triage ethics from ventilator to no ventilators. Initially, we said that children, do not allow them to go to grandparents. It is unethical for children to be allowed to go to grandparents. Today we know children cannot transmit an infection to others up to the age of 10, though the HOPES trial, which is on, will tell us the truth. Today, we know that menstruation reduces the illness severity. Another ethical point, initially we were saying it is unethical to give steroids, but today we say it is unethical not to give steroids early enough because inflammation is the cause of this illness. Initially, we said hydroxychloroquine for all, but ever since steroids came, hydroxychloroquine has no role because it's a weak anti-inflammatory, and steroids are a very, very strong anti-inflammatory. We started with late discharge, that you should not discharge a patient for 40 days, 50 days, 60 days. In fact, the first patient was discharged in India after 40 days. Now we are talking about 4th day discharge, 5th day discharge, 6th day discharge. Today, we are talking about pool testing. Initially, we said that it is unethical to open up institutions. Now we are talking about pool testing. 64 people's pool testing can be done. Results can be available in 2 hours. And if the test is negative, you know that all 64 people are negative. Now we have understood a new arena in COVID understanding that there are 2 phases of COVID. That is the first 9 days, that is COVID phase. During this 9 days, patient may have inflammatory reaction, thrombogenic reaction. During these 9 days, the patient may have a inflammatory reaction. And after 9 days, the virus becomes non-replicative, virus becomes non-culturable, non-transmissible in outpatient area and in ventilated patient after 20 days. Therefore, any illness after 9 days is a post-COVID illness. When we say post-COVID illness, it can be a post-COVID inflammation, post-COVID thrombosis, post-COVID immunological reactions. Therefore, after 9 days, a patient may have an illness lasting for 3 to 6 months. So all those patients where we were keeping them isolated for 3 to 6 months, now we know they are no more COVID. They behave like post-herpetic neuralgia or post-chikungunya persistent arthritis. Today, we know that we can calculate the cycle threshold value of a RT-PCR and know a low versus high viral load. So therefore, now ethics will change depending upon the viral load. Initially, we were talking about only antigen, and now we have antibodies, IgG, we have IgM plus IgG antibodies. So therefore, our way of management will change depending upon the availability of antibodies. Initially, we said isolation, so a lot of mental issues came. We talked about coranxiety, we talked about corona depression, corona panic reactions, because people were isolated. There was a fear of isolation. Today, we know there is a cohort isolation. That means multiple corona positive patients can stay together. And therefore, since we have allowed cohort isolation, the mental pressure has gone away, and we have reduced the isolation from 40 days to 4 days, 5 days, unless you are in a hospital. And now we have shifted from isolation to isolation for 9 days, quarantine for 5 days, and monitoring for a week, which gives them enough time. 9 days of isolation, nobody minds if there 2 or 3 people are living together, therefore anxiety levels are low. Another thing is we are shifting from government treatment to private treatment, no oxygen at home to oxygen at home. And then we are testing to no testing, no test, only symptomatic cases to asymptomatic testing. Now we are shifting from mandatory prescription from government to liberal testing. And now we are talking about 2 types of COVID, pulmonary COVID and a non-pulmonary COVID. A non-pulmonary COVID does not require any treatment. If you have a loss of smell, loss of taste, left eye involvement, if you have a cholecystitis-like picture, appendicitis-like picture, diarrhea, if you have a little bit of nausea, vomiting, if you have simple upper respiratory tract infection, you require practically no treatment. So we know that if non-pulmonary COVID exists, which is mild, and in pulmonary COVID, we have, in respiratory COVID, we have 2 types, upper respiratory infection and lower respiratory infection. So today we know only lower respiratory infection, which is 2 to 3% of the COVID patients will develop lower respiratory infection. And on day 3, 4, 5, and 6, you can pick up pneumonia, exertional cough and exertional breathlessness, and pneumonia with thrombosis, which is exertional hypoxia. That means happy hypoxia. So we know only pulmonary COVID needs to be picked up to reduce the mortality, to triage the patients. And today we know that asymptomatic patients actually really are not asymptomatic, because our symptomatic definition was pulmonary COVID, because large number of them have non-pulmonary COVID. Non-pulmonary means no lung involvement. They have upper respiratory infection associated with other GI and other manifestations. So they were being considered earlier as asymptomatic. High-grade fever, that was the initial diagnosis. We said no fever, no COVID. So there was a campaign that no fever, no COVID, no fever, no flu. We shifted to no, fever can exist, but fever is present in 99% of cases. But we know now today that fever may be absent in a large segment of the society. Fever may appear on day 2, day 3, or day 4. And now we are talking about exertional low-grade fever, which is inflammatory and not infectious. And today we talk about more and more of 6-minute walk test. We talk about more and more of 6-minute walk test. We are now shifting from joint families to nuclear families. We are not talking about toilet as a COVID box. Our contact time has reduced from 30 minutes to 15 minutes because of a macro to micro droplets. Now we are talking about no testing once a single test is positive, because the dead virus may remain for 40 days. Now we are talking about is low mortality to high mortality amongst doctors. Today we talk about social engineering. Today we are talking about social engineering, which means the screening method now has changed from a temperature checking to 5 things. Give him jaggery, do his sweet taste checking. If he can eat jaggery, say sweet. If he can smell a rose and he says, I can smell it's a rose. On exertion, if he has no temperature, on exertion, he has no SpO2 fall. And with a grip, if he can, his grip strength is normal. If 5 screening methods are normal, he is absolutely not having COVID at that particular time. He is not symptomatic COVID at that particular time, because these are the 5 social engineering tests. Therefore, today, just checking people, calling somebody as unethical because you cheated the airport by missing the fever test. Remember, fever will always come on exertion. Fever you cannot suppress by Tylenol the fever in these cases, because on exertion, 99.6 fever will come. Plasma therapy is another issue. Vaccine is another issue. Now I'm going to take up some of the ethical issues which we are facing. The major ethical issue is in India, we have 110 medical healthcare doctors' death. 2 more doctors died yesterday. Bangladesh has 83 deaths. So large number of countries are having deaths amongst healthcare workers. When I spoke to Korea, China, Hong Kong, New Zealand, Australia, Taiwan, it is unethical for the government not to provide an AII atmosphere when you are saying micro droplets is the cause of infection. Whenever we talk about micro droplets, which is always there in a healthcare setting, because the size of the droplets is less than 5 micron. In that consider you need an AII room, airborne infection isolation rooms. Less than 5% of the hospitals in India have that. Every hospital in Korea, China, Taiwan, Singapore, Hong Kong have AII room. And if you see Singapore and Hong Kong and China and Korea, the healthcare workers' infection rate is practically 0. Forget about the deaths. So one of the basic ethical issue in countries is that it should be called unethical for a hospital not to have AII room. You are calling a room as an isolation room by calling that I don't allow anybody else to come. And if you don't have a negative pressure isolation room, it is mandated that you have a stopgap arrangement with an air purifier with 6 exchanges per hour, plus a portable plasma unit to kill the viruses and the bacteria. Number 2 is that during this COVID era, all our professional autonomy is gone. Why? Because there was a fear. There was a fear from China, unpredictable, uncertain, death is certainty. Then we saw Iran, people dying like anything. Then we saw Italy, thousands of patients lying in the church, no time and no place for cremation. And that created such a pressure on the governments that governments took over the professional autonomy. WHO, CDC, government of every respective government started dictating treatments, protocols, everything. And with that, what happened was mortality did not reduce. And when private professions started coming in, private experiences started coming in, now we know mortality is an exception, not the rule. So therefore, professional autonomy is a must. You need to have the doctor decide on a case-to-case basis, because when you say that government dictates the treatment, treatment cannot be generalized, treatment has to be individualized. All governments started putting guidelines, but doctors forgot the word, it is guidelines and not a law. Guidelines can come by WHO, but WHO, CDC, any government cannot dictate guidelines as mandatory. You have to use your professional competence and you treat them. The third thing which came as an ethical issue is, and the very first CIMAO meeting we discussed about it, is a new convention, new Geneva, which is a declaration which says, I will attend to my own health. Initially, it was not there. I will attend to my own health, well-being, and abilities in order to provide care of the highest standard. So I raised this issue with WHO that if I am a high-risk doctor, if I have comorbidity, at that time, death was like created like hell. So they said doctors have a right to refuse to see patients if they feel their health is threatened. Because there was a ethics that for me, I cannot refuse, in times of epidemics, I cannot refuse a patient. But this year, Geneva declaration changed it and they says, I will attend to my own health. So own health has now become important, and therefore that changed the whole thinking of the whole world, and telemedicine now has been recognized all over. Telemedicine, which was never allowed, became ethical only because of this clause from Geneva Convention, from the Declaration of Geneva, that doctors' health becomes first. Another thing which has become an ethical issue is a person who dies of corona, his body is disrespected all over the world, specifically even in China. When it started, the bodies were disrespected, people started disowning the bodies. Now we know that once the person's dead body has been covered properly by a cloth, where is the question of an infection? You are not opening the body, you are not opening the cloth. Once the whole body is covered in a plastic bag, where is the question of getting infection? But that stigma hasn't gone. People have not allowed, even a person who died in India, a medical doctor, his body was not allowed to be cremated. He was cremated at 2:30 in the night in one area in the protection of the police without of the people being unaware of that. That was the level of, but today that ignorance has gone probably, but you may see these types of things in other countries. Another thing is that today the basic issue is CPR, DNR, and brain death. There was a time when brain death was not declared in any country because relations never used to allow, and they used to say that the patient, he is on ventilator, heart is working, and today they are saying declare that immediately. If it is a COVID death, there is a dichotomy in declaring a COVID brain death versus a non-COVID brain death. Another thing is that we are facing a big ethical issues in our AMR campaign. The whole antimicrobial resistance has gone for a 6. Every time we have been talking about do not give antibiotics, and now we are talking about must antibiotics in viral fevers. All our efforts of the last 20 years have gone into waste because of this virus which behaves unpredictably. Still, we don't know whether antibiotics are working or not, but this virus has totally changed our ethics. Now it will be not unethical. It will be unethical not to give antibiotics. If that happens, this will happen in diarrhea. This will happen in all respiratory infections. Now antibiotics will be misused much more, and there will be no government regulation for that. With that, then off-label use, basically every country is today, vaccines, drug trials are allowed. Practically every drug is being given a permission to do a trial. Even vaccines, you will see a vaccine coming without a 6-month safety. Normally a vaccine, we should have a minimum 6 to 9 months of safety protocol, because to see whether they are producing delayed complications or not. A vaccine may prevent COVID complications, but if it does not prevent post-COVID complications, which are lasting for 6 months, and they may appear 3 months after the COVID, which are all, it's like chikungunya arthritis. So we don't know how the vaccine will be allowed to be available. And if it is available, what will be the triage, how the country will distribute it to which segment of the society will remain a debatable ethical issue. Ventilator is no more a triage, issue, because now we know enough ventilators are available all over the world. CT value, whether to allow CT value or not is another ethical issue. Many governments are saying is we will not let patients know their CT value. CT value is a cycle threshold value. Lower it is, higher the volume load. Another thing which comes is over investigations versus under investigations. Initially, we were saying that over investigation is wrong, but now we know that whenever you are going for a CT scan, we are asking for a CT chest extra. And then whenever you are going for a CT chest, we are asking a pulmonary angiography, CT pulmonary angiography as an extra. So over investigations today are the rule because of a disease which is making you learn. Therefore, this formulation may change later on as a practical science. This disease has given us, specifically in Asian countries, now the cost of treatment in an isolation room, if I give in India as an example, is 10,000 rupees are being mandated by government. You can charge 10,000 for an isolation room. There are no isolation rooms because they don't have AII. So isolation here means single room. Single room now has become 10,000 will be a norm. That means post-COVID or from now onwards, the treatment of any treatment will be extremely costly, not only the COVID with that. Recently, there was a circular in India that people who are 65 plus, they will not be allowed to practice in cinema, commercial ads, which is absolutely unethical. Age cannot decide my way of working. Even government's decision as on today of not allowing 60 plus people to go out is also unethical, because today we know that outdoor infection is less than indoor, because wherever there is a cross ventilation, the infection is less. Antenatal care is another ethical issue, because whether to tell ladies to get married or not at this time, should they conceive or not, is at this moment, we still don't have any data. Should we allow IVF or not? There are guidelines available, but it will have ethical issues, because when the newborn is born, and if he has some disease, he has a right to file a case against the doctor. Why did you give the permission for that? Now, these are some of the school not opening is another ethical issue. When we know there is enough data to say children do not infect other children, why the schools are not opening? Is it fear? Is it lack of data? Is it the fear of unknown? We don't know. But as on today, we know that children do not cause infection to others, then why schools are not opening? Allocation of beds is no more an ethical issue today because most of the beds are now lying vacant in most of the countries. Even in Bangladesh, we had a presentation day before yesterday. Even they said large number of cases are going for home treatment. These were some of the points which I wanted to discuss as a point for discussion, open to the chair.
Dr. Derek, I think you can, Dr. Joseph. Yes,
there.
Joe, yes.
Thank you very much, Dr. Agarwal, for an outstanding, very rich presentation. I'll turn it over to Dr. D'Souza for the questions from the audience.
Yes, sir. Thank you. That was extremely lucid, and I think you covered most of the major issues. And what I loved was the way you started right from the very beginning and brought about the present day reality and how the complete understanding of this very complex disease has evolved literally sometimes from day to day or week to week. One of the questions which was put by one of the participants into the chat was, why are we subjecting all international travelers to a mandatory 14 days home quarantine when the virus is infectious before 9 days and symptoms are evident on day 3, 4, and 5 only? Your comment.
So the evolution is now they are doing 5 days of monitoring. That means if you are, see the question is, are you going to get infected from the origin of your travel in the airport or in the plane? These are 3 issues. Okay, the first issue is in the country of origin, you can show them that I have a tested negative report. That's one. Second is that you are now in the airport. Unfortunately, most of the airports are saying you need 3 hours stay in the airport. Every airport is non-cross ventilated. They are absolutely, their toilets are used by multiple people. Without ventilation, they are a big source of infection because micro droplets in the airport toilets will be very, very, very high. The lounges will be very high of infection because they are absolutely ill ventilated unless they have an air purifier and a plasma, which may not be evidently present everywhere. So therefore, high chances if you stay in an airport for 3 hours, there are high chances of acquiring an infection. In the plane, the chances of acquiring an infection are minimum because of the laminar flow. The flow from top goes to the bottom. All the viruses will be on the bottom. Therefore, in the plane, if you are not eating any food, because if they take the table out, it may have some infection. If you are sitting on a window seat, your chances of infection are the lowest. And if you are waiting for toilets to be shared at least for 5 minutes after somebody has used it, your chances of getting infection in the air are lower. When you come back to your destination, then you are again traveling through the passport, where the person who is sitting and stamping your passport is the highest risk because he is meeting multiple people. And if he is taking more than 5 minutes of your clearance, you are at risk because it all depends upon, then you go back to the custom clearance, how much time they take, because they cannot do a custom clearance without coming 3 to 6 feet close to you. So therefore, you have a theoretical possibility of acquiring an infection at so many other sources. And in that particular case, when you are freaked, when you are checked by the security, again, they cannot check you from a 6 feet distance, depending upon the country. So therefore, acquiring an infection is a theoretical possibility. Therefore, 5 days quarantine is a must today, not more than that, because we know average incubation period is 5 days. And these 5 days now it is monitoring and not quarantine. Monitoring means wear a mask, monitor yourself, stay in an area. You can mix up with other people. And if you do not acquire any infection in 5 days, you can go back. So 14 days quarantine is no more recommended, it's 5 days.
Thank you. Thank you. Thank you, Dr. Agarwal. I think that answers the question quite clearly. Your take on asymptomatic carriers, sir?
So normally, I might have interacted with at least 5,000 patients in the last 1 month. I don't believe in the word asymptomatic. If you explore them deeply, they will have some symptoms. They will say, oh yes, I had a little bit throat irritation for an hour, and that was 4 days back. So this disease is so unpredictable. It may have a symptom today. 2 days you may have no symptom. 3rd day you may have another symptom. 4th day you may not have any symptom. 5th day you may have another symptom. Now it comes back is which is day 1 or which symptom you have to take. So if you get a test done today, people will ask in the last 48 hours, did you have any symptom? They will say no, you say asymptomatic. But if you ask them in the last 2 weeks, did you have any symptoms? Or the last 2 months, did you have any symptoms? People may actually come back with some symptoms. Or if you say that in my family, nobody had symptoms, then you are asymptomatic. But if in your family 4 are positive, and if you are asymptomatic, then actually you are not asymptomatic. If asymptomatic, so therefore mild and atypical symptoms actually happen much more than asymptomatic. True asymptomatic will be there, but not that much.
Right, sir. As a follow-up to that, as you said, we are seeing so many different pictures. And again, you mentioned about the shortening of the hospital stay, and again, people are being at home quarantine. So how do we distinguish between post-COVID complications and a new COVID infection?
So new COVID infection, theoretically, there are only very few viruses who have a reinfection. One of them is herpes zoster. But as on today, because in India, virus culture facilities are only available with NIV Pune. I have checked it with most of my neighboring countries. They don't have a virus culture facilities. So therefore, the data will come only once we have a data as a single case report that your virus has been, the virus reinfection has occurred. So as on today, we are not believing in reinfections, number 1. Number 2 is RT-PCR is 30% false negative. Rapid antigen is 50% false negative. Therefore, first test positive, second negative, third positive does not mean that second was true negative. So therefore, a non-culturable virus can persist for up to 2 months. And when we talk about post-COVID phenomena, so in a post-COVID phenomena, we have to see which complication we are seeing. If it is a post-COVID hypercoagulation, then you have missed high D-dimer on day 3, 4, 5, and 6. Then these patients may present with post-COVID heart attacks, paralysis, they may have post-COVID skin thrombosis, they may have post-COVID gangrene. Now, these are the patients where pulmonary embolism and they can die. In fact, the first patient died in the country was an Italian doctor who had acute MI on 14th day and died. Number 2, you can have post-COVID thermodysregulation. Thermodysregulation means that your body's temperature has been reset. You will either feel a low-grade temperature, exertional, or you have a feeling of chills. You will have a feeling of chills, but your parameters of inflammation will be negative. You have normal CRP, you have a normal ESR, and then you have fever. This is thermostat dysregulation. Third, you will see signs of inflammation. There you will find high ESR, high ferritin, and high CRP. So this is persistent inflammation post-COVID, which can present with a left eye conjunctivitis. When I say left eye, means left eye conjunctivitis, cholecystitis, appendicitis, tonsillitis, intestinal inflammation. All these things are signs of inflammation, and that will present with high ESR, high CRP, and high ferritin. We give them a short course of steroids as an anti-inflammatory drug, or give them colchicine, or give them hydroxychloroquine. Then you can have a third is immunological reaction, that is cytokine crisis, occurring on day 14, 15, and 16, which is the cause of acute death on day 14, 15, and 16. That again is impossible without a thromboinflammation. So if you miss a thromboinflammation on day 3, 4, 5, 6, you had it, you can end up into a post-COVID complications. Otherwise, all post-COVID complications are manageable. And what we have been talking for the last 2 months, CDC only came back day before yesterday. Yes, 2/3 of the patient in the post-COVID phase may have a chronic COVID. They are naming the term chronic COVID. I don't agree with that term of chronic COVID. I'm calling it as a post-COVID, because if you say chronic COVID, insurance will not pay, which is not COVID, because COVID is gone. And if you say chronic COVID, you will have an ethical issue.
True, true. Well said. I think we have to be careful in how we put things down on paper, as you said, in trying to be overcautious. We may actually be harming the patient from the other issues. And I'm glad you highlighted that point. We are very honored to have a former Vice Chancellor of Tamil Nadu MGR University and a person who is an authority in her own right, Dr. Geeta Lakshmi. Welcome, ma'am, and your comments, please, or questions.
Yeah. So thank you for getting into the discussion, and thank you, Russell, and the other coordinators, and Dr. Agarwal. There are questions I would like to ask, and I also on ethical issues. As you said, like I've seen in a cohort admissions, which you said, I've seen many of the doctors say that the nearby patient, when they see the other patient dying, they out of fear, they die. That is what an answer I got from some of the doctors working in a government hospital, where there was a cohort admission of these patients who had oxygen therapy and prone position, all those things. And the second one is the constant person-to-person individual attention has to be made to bring down the death rate. The death is mostly because of, I would say it's because of negligence, because when we monitor those patients carefully, one-to-one, and see that how they had been fed and how they are positioned and whether the medicines are being given properly, definitely there will be not much of death. And as you said that 0.38% is the death rate, but here we can also bring it down. The other one is I've seen in post-COVID, they develop sinusitis, they develop middle ear infection, and which constantly it is there for these patients. There are few patients which I have come across. They have this middle ear infection as well as this sinusitis with them for past 3 to 4 months after the COVID infection. And this has been like when the immunity brings down, they have some mild symptoms of corona, which we say like having burning sensation in the throat, lighter headache and chills. This is what I've seen in some of the patients. And in that case, when the treatment was just with the inhaling of steam and drinking hot water and menthol and camphor inhalation, it becomes all right within a day. The other one is I found out like most of them who are what we say as asymptomatic, they have symptoms, but when they come to the surgery of any other surgery, when CT scan is taken, they have a ground glass appearance, and then they are treated for this COVID-19. And this is what, because when they are taken for another surgery, we find out they have these symptoms. And now I have to know, like, what is the chronic infection, which you said, and reinfection, like herpes zoster, chicken pox, the HIV, where we have the infection dormant, and it gains when the situation arises or it wants to survive, it again multiplies. So I want to know like the chronic infection and the reinfection. And as you said, that plasma therapy, it has become a necessity right now, where we in Chennai and in Tamil Nadu, we have started the plasma banks in many of the blood banks, and it's given a very good result. And the other one is many of the, as you said, like why don't we open schools? Schools can, whether it is because of fear or because of the lack of data. I would say it is because of the lack of data. If somebody gives the data, proper data, or altogether when we work on it, we can give the government that this will the infection is not transmitted through children. But anyway, as you said, like the infection may arise through the adults, who the teacher or wherever the children plays goes around. So that is we have to discuss on it, why the schools are not reopened. And the other one which we said, like it is 10,000 rupees for a single room. And I would say like there are some ethical issues also arising in persons who are going to who are stuck up in India when they are given a charter trip to go to their own country. What had happened? Like I have one incident. Like one family after about 4 months they wanted to go back to Malaysia. But what happened when they landed in Chennai? I had to help them. When they had landed in Chennai, all the family members were tested and for COVID-19, and was found that the husband was positive and the 2 children and the wife was negative. The flight was the next day, and by 10 o'clock, and the lady became panicky. What happened? The husband was taken away to another quarantine area, and the lady and the children were, they were taken to a hotel. Then because of my help and saying that if they are negative, they would be quarantined in Malaysia. The family was sent, but she didn't know where did the husband go and where was he quarantined. That was the state, like where the spouse is quarantined or the close relations are quarantined. It took a lot of time for me to find out through the collector, because it comes under the Chengalpet district. So I had to go and contact the collector and the director of medical services to find out where the husband was. So that is an ethical issue which I had undergone.
Thank you.
I had. So I want an answer for these last one also. Thank you.
So I will get all the answers. Thank you, Gita madam. One is cohort. When I say cohort isolation, I'm talking about cohort isolation even at home, even in the community. So if I do a cohort isolation at home, if one is positive, I can advertise that anybody who is in my family positive, let's stay together. So if you have a cohort isolation outside the hospital, multiple people, then you take care of their mental anxiety. In ICU, in any way, cohort is always there. In ICU, all over the world, all patients, serious and non-serious patients, are in the same ICU. But I'm talking about a non-ICU situation, cohort, where a person is isolated for 9 days. Like you said, husband and wife are isolated in a separate room. Why? They should have been living in the same room with masking and maintaining a physical distancing. Now, the individual attention, I totally agree with you that individual attention today or tomorrow will come. The reason being, people are afraid. Even one of my doctor, when I interviewed him day before yesterday, he says, when I was admitted, even other doctors were afraid of coming and even touching me. That problem will stay till the fear lasts. Sooner or later, that fear will go away situation. Then madam said, post-COVID, sinusitis and ear involvement is extremely common. In fact, 70% of the people with loss of smell and loss of taste will have an ear involvement. And that ear involvement is a serous middle ear infection. It's not infectious. It's a serous. It's an inflammatory sinusitis. It's an inflammatory cystitis. You will get a large number of patients with urinary symptoms. They have pus cells, negative culture, negative bacteria. So this is more of a inflammatory sinusitis, serous middle ear syndrome. If it is present, it can appear anytime for the next 6 months, like a post-chikungunya arthritis. It does not mean a reinfection. So you may, if you get today a patient who is having a serous middle ear inflammation, you ask him, did you in the last 3 months, did you had any problem? He says, no. Okay. Did you had anything here in the throat? Oh, yes, I had a throat. I said, anything, any person else? He says, yes, my mom at that time had a single diarrhea. My father at that time had a little bit nausea, vomiting. My dadi has a loss of appetite. It was all COVID. 2 months back, which they missed. And at this moment, this is not a new infection. This is a post-COVID inflammatory cystitis, cholecystitis, appendicitis, sinusitis, tonsillitis, and serous middle ear syndrome with that. When we talk about surgery and CT scan, I have already said that it is ethical for me, because if I do a surgery in a COVID positive patient, mortality is 10% because the person is highly hypercoagulable. And during surgery, if he has a clot, I cannot give him heparin. Therefore, I can ask for three things. I can ask for his RT-PCR and a pooled RT-PCR of his family. If both are negative, he has no infection. And if he is undergoing a CT scan for any other thing, suppose he says he has a urinary problem, he's going for a CT urography, always do a CT pulmonary also. So whenever you are doing a CT scan, also look for a CT pulmonary. Always get there. Initially, we used to say for a pre-operative evaluation, chest X-ray is not necessary. Now we say get it done. Now we say any CT scan, go for CT chest also. And if you are going for CT chest, also go for CT pulmonary angio. That covers the answer with that. When we talk about chronicity, I'm talking about after 9th days, all symptoms can come back and come and go. They may be associated with high ESR or CRP. They may not be associated with that. Then this virus can precipitate other viruses. So we have seen large number of herpes zoster. We are seeing large number of cases with facial palsy. We are seeing cases with chronic fatigue syndrome. So there are people who are ending with chronic fatigue syndrome. This is causing a mumps-like reaction in many people because they're having a post-auricular lymph node with a transient rash. Therefore, this virus can precipitate other co-viruses. So these are not a herpetic reaction, but it is precipitating other reactions. What is the reason? We don't know. Plasma therapy, yes, as on today, but plasma therapy's role will start reducing because with the early use of steroids. Plasma therapy was very useful because we had no drug, but today we know it is the inflammation which is causing death. Therefore, plasma therapy's role will start getting down as and when we start using early corticosteroids. Schools, I totally agree with you that you say the evidence is needed. The evidence is, reverse evidence is needed, not the evidence. Today, we have no evidence to say that children spread the infection. So we need an evidence to say children spread the infection. And HOPE study, international trial is going on for that, only to answer that query. As on today, we have not even a single case report where a child has infected any other person. I am doing a study in India that who is the first person in the family to get infected. I still don't find a child to get infected as the first case. And all the cases are adults first. And if out of 6 people, 5 get infection, if 1 is spared, it will also be always be a child. Teacher to children cannot happen. Child to child cannot happen in a school because they are not facing face to face. No child is facing face to face, like in a train, bus, or in a school. You are facing the back of the other child. So even if you cough, it will go to the back of the other child, infection cannot come. Teacher always 9 feet away from the child. And number 2 is 10 years of child is in height much lower than the teacher. Therefore, face-to-face contact is not there. But if you are plus 10, yes, if your age is plus 10, then you are having face-to-face meeting with adults, chances of infection are there. And then this international people that you are quarantining husband and wife separately, I've already said that today all family members can stay together in one room like a hospital. You can play, you can dance, you can do everything, and you can help each other. But we do say that even after quarantine, even during quarantine, after post-COVID phase, you need to wear a mask. The reason being, when this virus goes, he will tell his other co-viruses that this guy has a lot of weaknesses, you go there. Therefore, to prevent co-infection or super-infection or a secondary infection, masking should continue.
Thank you, Dr. Agarwal. We also have Professor Ashraf Nizami, who's president of the Pakistan Medical Association. Thank you for being here regularly week after week. Good to have you. Your comments or any questions that you would like to put to Professor Agarwal? You can unmute yourself, please.
Thank you very much for giving me this opportunity. Although we speak every week on Saturday with Agarwal, and still we are under discussion because Agarwal is very much supportive and he speaks about that the schools can be open, whereas my personal perception is that children are not the robots. They don't sit in the classroom, just state and they look at the teacher with a distance. Children are children. They play, they communicate, and I believe over here in Pakistan that once we are going to open the schools, and we have seen over there the mortality in children too from the COVID, and there is the infection of by the COVID in children, and there are reasonable studies from states and here from Pakistan also we have gone through. And when I presented in Simao, I talked about it, particularly about the children, and we are very much concerned about it. And the Kawasaki disease, that is one of the reasons, and that is the complication of the COVID. So it cannot be simply to opening the school as my president, Simao Agarwal, he feels. I appreciate his concern and conviction that the children are immune to the COVID, but the teachers are over there, the school officials are over there who have to work over there, and it is not a clear chit that the children do not get infected by the COVID. Just a few words about Pakistan, that we are on a reduction. In Pakistan, luckily, we have gone down. The infection rate is very low. The death rate has gone very low, but it is true that we have infection in the health professionals. Doctors are giving their lives over here in Pakistan, very unfortunately. And as far as the virus laboratory testing is concerned, we in Pakistan, we do have in Islamabad and some of at Lahore too. So 2 laboratories are in Pakistan which are working over there. Thank you very much for giving me this opportunity.
Thank you, Professor Ashraf. I just want to add is this is the hottest debatable issue to open or not to open, because if we ask such a simple question, it would have opened up so far. So number one is US. When I talk to US, American Medical Association, and Joseph Thornton will point me out, their policies are that they will be doing a pool testing to when they start the schools. In the initial month, they will do a pooled testing of all the children of every class to find out what is their infectivity rate. When we do pool testing, Singapore has a pool testing of 64 people together. That means for 64 samples can be converted into 1 sample, and you do RT-PCR. And if they find in the school any child is positive, they will shift to a virtual training for that week till they detect who is the source. That's one way people are talking about it. I attended a WHO seminar on schooling opening, where all the countries participated from WHO. I was representing the CMAO there. And WHO says they do not recommend masking in children, but it is left to the countries to decide. So they were, even WHO was talking about, like what Ashraf is saying is that children are not going to mask themselves. They are not going to take precautions. So therefore, masking is useless for them. But they says, let the countries decide their own protocol. But many of the countries were talking about masking is not useful. When I say child means less than 10 years. I'm not talking about 11 years as a child. For me, that's an adult. So less than 10 years are not going to behave social distancing. They are not going to behave physical distancing. And now they are saying is when they have no infection, chances of infection, why take care? Why behave with them? And the third is that when they meet the teacher, there is no face-to-face meeting because of the height. Because 10 years of child is in height, the height is much smaller than the teacher. And when they hug the teacher, their viruses will be at the teacher's chest, not on our face. So surface to human transmission still will be there. So therefore, whether to open or not is a debate. It's still going on all over the world. But I personally feel school must open, whether you mandate it or not, because it is going to harm the whole country by not opening the schools. So ultimately, it has to open. Consensus needs to be developed on a country-wise. And in any country, the situations will be changed. In India, I know schools will never open unless the Supreme Court intervenes, because every father will file a case and he says that my child, my child, my child. But yes, it's a debatable ethical issue whether we open it or not.
Oh, Professor Joe, if you could, yeah.
And I think I will comment from the U.S. Perspective. Basically, we're going to have multiple experiments by nature. There's so much diversity in the way the schools are organized and the governance of the school. So no one entity really controls them. And then the parents, if they have the means, have the ability to opt out of the schools. So we're going to have many natural experiments over the next couple of months that hopefully we'll get, we'll learn from the experiences. But it's a scary time for everyone, hotly debated, and no one way is going to happen.
I just want to add, with the permission of the chair, that children do get infection. I'm not saying children don't get infection. I said they are, number one, if somebody is spared, it will be a child. If nobody is spared, children will also get it. Somehow or other, inflammatory conditions we are getting more in Europe and US. So we are not getting inflammatory Kawasaki multi-system infections in children in the continent of, I don't know, because Professor Nizami said a couple of cases they have seen in Pakistan, but that's not the rule. We have more of a less inflammatory condition. That's the reason our mortality is slightly on the lower side. So there is an experiment available in India. So there are hundreds and thousands of schools which are called Ekal Vidyalaya, where Ekal means one teacher, and the one teacher goes to a poorer section of the society, and they open a class in an open area near a tree. So these schools are hundreds of thousands of schools are available in India where there is no building. All the classes are taken in open space, and where the one teacher is there, he spends the whole day time with the school children and they teach them. And the study available shows none of the child from there till today has developed corona. So because they say that because ventilated, cross ventilation, sunlight available, and children, physical distancing possible, and one teacher, so discipline is easier with that. And yet, because I interacted with them 2 days back, and Ekal Vidyalaya, where millions of students are studying there, they did not find even a single corona patient so far. That's one study available for consideration.
Right. Thank you so much, sir, for giving us those few experiences that you shared. As we said, we are still on a learning curve. We are still trying not to make any mistakes, because in the past, there were a lot of knee-jerk reactions, if you'll agree with me, both on the part of the government and the regulatory agencies. And unfortunately, everyone wants us as health professionals, or even at times we expect the government to come out with a guideline, or we want them to come out with something. And there's no real evidence in any fixed direction, which actually ends up causing confusion. And even HCQ is still being debated. And what is your current take on all that, sir?
See, when I say as a prophylaxis, I am still taking it. Why? Because this is an anti-inflammatory drug. HCQS is 100 times safer than chloroquine, because hydroxychloroquine came only because of the toxicity of chloroquine. We give hydroxychloroquine in psoriasis, in rheumatoid arthritis, in Crohn's disease, and so many other diseases. It's safe. It is anti-inflammatory. It is not, its antiviral effect is debated. Therefore, its role in corona has gone because of steroids, because steroids are much potent anti-inflammatory drugs. So initially, HCQS showed some results, people were not using steroids. So today it has no role in the treatment. In the prevention, we are giving it that because it has some anti-inflammatory effect. Maybe if you miss the diagnosis on day 3, day 4, or if you have very high inflammation on day 1, if there is some hydroxychloroquine in your body, it may prevent cytokine crisis. That's all.
Right. We also have Vice Chancellor Professor Shashank Dalvi with us. Sir, your comments and any questions if you have, you can unmute yourself, please.
Good evening.
Yes, sir, go ahead.
Good evening to Dr. Russell. Good evening, Dr. Agarwal, sir. Sir, I would like to have your opinion on the drug fenofibrate. That is in the Israel recently, the study that they have shown, and they are claiming that this is the virucidal, and in the lungs, when that is inflamed very much, the total viruses the drug will destroy. This fenofibrate, which is also used in cardiovascular diseases, particularly the lipid lowering drug disease, and that the
So today there are at least thousands of drugs which are being experimented. One is any drug which has a weak or strong antiviral activity. 2, if it has anti-inflammatory action. 3, if it has some cytokine prevention action. So there are thousands of drugs which are under role. Colchicine, yes. Dipyridamol, yes. Prazosin, yes. Statins, yes. Fenofibrate, yes. All this, see, fenofibrate and statins have pleiotropic effect, because whenever we talk about low-grade inflammation, CRP, so all those drugs which lower CRP from 1 to 0.6, from 0.6 to 0.3, these are called pleiotropic effect. Fenofibrate is one of them. So therefore, we say that any patient who needs a anti-cholesterol drug, give it today. Now we are also debating about BCG and MMR vaccine. So all vaccines which are live attenuated vaccines, if given today, will produce higher innate immunity and may be effective. These are all if and buts. Now we are talking about plasma therapy in the elderly. Suppose I have an infection today, my parents are at my home, they are 60 or 70 plus. Can I give them prophylactic plasma therapy? Trial is going on. So today, anything which you feel is anti-inflammatory and anything which is a astringent taste. Now you see, anything which has an astringent and bitter taste is drying. And this virus is a wet virus. This virus has a lipid layer. This virus cannot multiply outside my body. Therefore, anything which is astringent and bitter taste may affect, because it has antiviral and anti-inflammatory. And now we are talking about insulin resistance, because we know that hyperinsulinemia causes inflammation. So now we are talking about, all diabetics are talking about, you take dalchini, you take cinnamon, you take all those things which reduces hyperinsulinemia, may reduce inflammation. Now all dietitians are talking about each non-inflammatory diet. All are fine. All are fine. Anything which reduces inflammation will work. But. We are now giving steroids. Steroid is the strongest anti-inflammatory. All other finds no role. Unless we have we are looking for a steroid-sparing anti-inflammatory agent, and that will be the answer. Tocilizumab is a steroid-sparing anti-inflammatory drug. So what we are looking for is a steroid-sparing, disease-modifying drug for COVID. as we have for other meds. So we are looking for DMRD, COVID DMRD, which is steroid sparing. But as on today, we don't have one.
Thank you.
Uh,
Thank you, Dr. Agarwal.
Can I?
Yes,
can I,
Dr. Russell. Dr. Russell.
welcome, Dr. Dalvi. Dr. KK, can you tell me about the vaccines? You know, we're hearing there are many vaccines. What is the obvious? That's going to be the big answer from what you're saying. So, what's your current
Okay. So
update?
let me take a couple of minutes to make everybody revise your definition of a vaccine. So if I introduce a virus in my body, then I will produce natural antibodies. This will be a natural vaccine, which UK proposed. Ethically, it was debated and it said it's wrong. It was something like rubella parties in the past, that you purposefully infect people of a particular generation and create a herd immunity. That's one. Second is that if I cannot introduce a live virus, I can kill the virus and introduce. That is called as a killed virus. Many companies are working on a killed virus. You can kill it by radiation, you can kill it by heat, you can kill it by formalin, you can kill it the way you want. Third is you don't kill the virus, you only attenuate it. You reduce its virulence. So that is called live attenuated virus. Indian Covaxin is a live attenuated virus. So it is a live virus, but attenuated, therefore cannot be given to people with immunological problems. Because it is a live virus, but of an Indian strain, it may prevent chronic complications. We don't know. But will this being a live virus, will it prevent chronic complications of COVID? We don't know. Post-COVID reactions, will it prevent or not? We don't know. The third is, you don't use the virus, you use a component of the virus. This virus has 4 components: RNA, a undergarment, which is called as a membrane, then a shirt, which is called as a envelope, then it has a buttons on the shirt, which is called as a spike. So you can use a spike as an antigen, you can use a membrane, envelope, or the RNA itself. Most of the people are now working on a spike. Now, is a spike responsible for all the presentation of COVID? We don't know. Therefore, if you have used spike as an antigen for vaccine, it will prevent only spike-caused diseases. Still, we don't know what envelope is causing in my body, what membrane is causing in my body, and what mRNA is causing in my body. Now, this spike, when I use, so I can use some other virus and change their spikes. It's something like I take your shirt and put my buttons into it. That is called vectored viruses. And that is what Oxford is doing. They are taking adenovirus of chimpanzee and they are putting the genetic material of this virus and putting it there. That's an adenovirus. So adenovirus is taking the American strain of spike of a virus, putting it into the adenovirus and converting that into a vaccine. And they are showing that we have produced antibodies, cellular and humoral, but will they be neutralizing? We don't know. How long they will be lasting? We don't know. Then came Moderna. He said, forget about the virus. Let me produce a recombinant virus, which is artificial with no virus, which is producing a spike-like genetic material. That's mRNA, and that's Moderna. And what they have said is, this virus reduces cytokine storm, but does not reduce the viral load. So we don't know what does it mean in a long run. How much is, therefore I said CT value becomes very important, because with this vaccination, virus will come in the body, but will this prevent only cytokine crisis or others? We don't know. Then China came. The China said, let me also produce a vaccine. And they says, let me also copy what Oxford is doing. Let me also take an adenovirus, but instead of putting a live spike protein, let me put a recombinant antigen there. So that vaccine now also is on a phase 3 trial. And they are showing that antibodies are producing. Then came other companies, they says, forget it, let's use a virus-like platform. Let's produce a DNA vaccine and a RNA vaccine. Let me produce a DNA platform and put a genetic material into that. So all sorts of companies are producing vaccines. As on today, the main aim of a company for producing a vaccine is to improve its economy. Every country is in an economical shutdown. As on today, the war is to improve their economy of the country. Therefore, everybody is racing. They are competing with each other. They are putting a blame on each other that you have hiked my technology. Otherwise, if it was humanity, all of them have stood together, decided one and done a trial together, which is not happening. So which trial will work, we don't know. Which vaccine will work for which company, which country, we don't know. A, Moderna, because it is a synthetic, may work all over. B, Indian vaccine may work for India because Indian strain. C, the vaccine from China may also work because they have a synthetic material within adenovirus. The adenovirus of Oxford may work in European countries because it has a viral strain of that particular country. So it's all if, and if. Today, it's all if and if. Will it prevent? Because unless you have given it to a healthy volunteer for 6 months to 1 year, you cannot say it's safe. You may give a vaccine. Without vaccine, he would have developed a mild infection. But if with vaccine, somebody develops a severe infection, it will be unethical. So therefore, all permissions are being hastened by the company. And if you see, every country is producing a vaccine with an interest of that company. In every company, in Indian, ICMR is with it, NIV is with that vaccine. If you go to the US, NIH is with that vaccine. So in every company, there is a government body because they want to improve their economy.
Very true.
They are
Very
part
true,
of
sir.
it. Even Israeli government said, the health minister said, tomorrow when they brought out a monoclonal antibodies, when he did a press conference, he says, our government is going to patent it tomorrow. So I'm a little bit skeptical about what actual the theory of vaccine is. Derek.
Thank you.
One moment, KK, Dr. KK, you spoke about the human challenge vaccine was not ethically acceptable. Is that right?
Which one?
The human challenge, where you put the vaccine, you infect the person and get the vaccine, isn't it?
Yes. I'm talking about a live vaccine, live virus, infecting people of a particular segment like children to create herd immunity. This used to be happened into a rubella parties. There was a time when rubella parties used to be done. All unpregnant, all unmarried women used to be called for a party exposed to rubella patients so that all get rubella before they get married. That used to be a live exposure of a virus. This was promoted, and some of the doctors in UK, they said, why don't we do that? But in any way, that was unethical. You cannot expose a society with a virus without knowing how that virus is going to behave.
So,
Professor Agarwal, but WHO is recommending that challenge.
Yeah, that's why I just said on May 6th, the WHO issued a document, key criteria for ethical acceptability of COVID-19 human challenge studies. And it states that there is a conscientious among ethicists who have reflected upon the human challenge studies that the intentional infection of a research participants can be ethically acceptable. While that is probably true for most ethicists, the WHO lists of ethical criteria for acceptability of such studies for COVID-19 does not mention the requirement that there be an acceptable treatment for the disease. So again, on the 6th of May, this is it is quite an ethical issue where you infect, and it's called the human challenge studies. And I think this debate was going on, but on the 6th of May, they've come out and said that it is acceptable ethically. So I just thought.
Thank you for the information. But This is going to be if you're doing it as a trial, it's okay. But if you're doing it for the community, thousands of people and lakhs of people, if you want to do it with an intention of producing a herd trial, herd immunity, I think it's not correct. But if you're doing it as a trial, if you're doing it as a trial, because when WHO allowed that human challenge studies was as a part of vaccine production, and that's a part of human challenges was different issue. But what I'm talking about is to produce herd immunity, 60% of the society, you expose them to the antigen without knowing its results is unethical. This is what I said. But I'm not talking about studies done by WHO for the purpose of producing a vaccine or for the purpose of producing, but you are not doing it to produce a herd immunity.
Yeah, but even to produce a vaccine, that is questionable, and that's why they even now still it's a questionable issue about the ethics of it, and that's why they had to produce something like this. And why was it acceptable? Yeah, or human
and there are some debate going on also to omit animal studies and directly challenge the human beings with the vaccine. That's also under consideration. That without doing because of the urgency, you can get away with the animal studies and directly challenge the human beings with that. But that's again experimental. That's again under a regulation. But I'm talking about unregulated herd immunity, 60% of the society, you take them in a park and you say you are exposed to the virus. No, that's not
ethical.
That's not ethical.
Professor Agarwal, they're saying that now the antibodies that are produced do not last. That is one thing. And the second thing, it is now thought that the pathogenesis is T-cell mediated immunity. Can you tell us something about it?
I agree about this. Number one is when we talk about this antibodies, we are not detecting neutralizing antibodies. We are only detecting IgG and IgM antibodies. So therefore, antibodies does not tell us the immunity. We will only get the immunity if we know the neutralizing antibodies and their titer. Titer should be more than 1:640 if you say these are good neutralizing antibodies. 1:80 is also acceptable, but that testing is not done, not available. So therefore, today when we are giving plasma therapy, we are not checking the neutralizing antibodies with that. Number two, there are two types of body reactions. One is a cellular, second is a humoral. So in a cellular, we have T cell. In a T cell, we have a CD4 cell. And in this disease, we are getting a low CD4 count. It is the same CD4, which we used to say a low CD4 count of less than 200. You treat a patient with HIV. And if it is more than 500, you don't treat a HIV patient. These are the same CD4 cells, which we are seeing lower in this particular condition. Therefore, cellular immunity is very, very important for cytokine crisis. Therefore, what we are talking about is, therefore, Oxford vaccine says, I am giving you humoral as well as cellular immunity. Moderna has not talked about it. They says we are giving you cellular immunity. We don't know. So all these questions will come later, whether even today, if I am antibodies positive, I may still be neutralizing antibodies positive. I may still be reacting to cytokines. Now, there is a study available from Singapore, and they said that a large segment of the society who suffered from SARS-1 or who suffered from SARS-2, they have cytokine cellular immunity lasting even today. Okay. So what Singapore is saying is that in our country, all those people and even those who did not, because over a period of time, they have developed cytokine cellular immunity. Therefore, they are protecting from SARS-2. So therefore, cellular immunity may be much important than humoral antibodies, but at this moment in Asia, nobody is working on them. So I am pretty sure today that because in children, you have a thymus gland, and that thymus gland is responsible for cytokine production. That gives you cellular protection. Therefore, children are having a milder disease than the adults. So therefore, cellular immunity in this particular condition is much more important than, and you have, we know that ACE2 receptors are present in the thymus. So therefore, somehow or other, I personally feel cellular immunity is much more important than humoral immunity as far as COVID-2 is concerned.
Okay.
I agree with you.
Professor Agarwal, just one more question as a pathologist. Is this virus, is 10% buffered formalin, does it kill the virus? Because all our specimens come in formalin?
Yes, absolutely. It kills the virus, formalin kills the virus, and then betadine 0.1% kills it in 10 seconds. Formalin kills it. And so this virus is very, very sensitive to anything which is an alkali, because this is a lipid layer. So anything which is an alkali will kill the virus within 10 seconds to a minute. Unfortunately, with a study which came that it lasts in the surfaces for 3 days, has never been proved again. There was only one study which talked about copper 4 hours, cardboard 1 day, and plastic for 3 days. I think that study needs to be challenged and needs to be redone, because everybody now is afraid, because surface to human transmission has not proven to be very, very important in this condition. It is the droplet and a micro droplet infection which is much more important than a surface to human transmission.
Okay, right. Thank you, Professor.
Yes,
Hello.
Dr. Gita
Yeah.
Lakshmi wanted to follow up.
So,
please,
Dr. KK, I have seen I've seen in many of
just for the chair, because in another 25 minutes I have another show. I'm anchoring one show in India, Med Talks with Dr. KK Agarwal, where I meet an expert every day, where I will like most of you, if you want to interact with me, it's a half-an-hour show in India every day, and which is attended by approximately 50,000 people on a daily basis. Today I'm debating on plasma therapy. So I would like to be excused in another 15 minutes. And after
this is the last question.
Just the last question.
Even if it continues, Mary Matthew will become a ghost Dr. KK Agarwal and answer the question.
Okay. So right, I want to know, like, it is the cluster which gets infected, and they say there is no community spread till now. And I wanted explanation for it. Number two is, as you said, pool testing. Only 64 people have to, where the sera is pooled, and then you do the testing, and then find out through the symptoms. That is what I understood.
I will tell you. The community, when we talk about pooled testing, ICMR says 5 people's pool testing. Kerala government says 20 people's pool testing. Singapore says 64 people pool testing is possible. So if you do a pool testing of 64 people, if the test is positive, then you know that somebody is positive. Then you do next pool of 32. So if that 32 which is negative, you say you are negative. Those 32 you are positive. Now you do a pool testing of 16 by 16, then 8 by 8. When it reaches 8, you do a test for everybody. So this is how you can, in 4 hours time, you can find out of 64 people who is infected. And what was your first question? Community spread, yes.
Yeah.
Community spread has different definitions. The first definition is, it is a animal to human. So first is a animal to human, then human to human. So when you say human to human, this is the original definition of community spread. Because now it has come from one person to another. That's the correct definition of a community spread. Then came back, no, this is not community spread. We need to divide that community spread into, we say index case, we say primary case, we say secondary case, then we say there is a outbreak and there is a community outbreak. And we started defining that the first novel case is an epidemic. First novel case is always an epidemic, not a local outbreak by definition, because it's a new virus or a new bacteria. So therefore, the first case in the country will be called as an epidemic and not a pandemic, not a local outbreak. Now in India, they say that community transmission have not occurred, because they say uniformly in India, all states in every situation, every district, the rates are different. So they say Delhi is an outbreak. Now, if you call Delhi, Bombay, Bangalore, Hyderabad as an outbreak, then I know community spread has not occurred. But if I say that Delhi is in community spread, Bombay is in community spread, then Chennai is in community spread, then it's a different story. It all depends upon your definition. Then by definition, they say that 70% of your cases says, I do not know the source. That means your secondary attack rate reduces. And you say, I don't know from where the infection came. That's the definition India is adopting for community spread. So India is saying definition of a community spread is if 69% of the people you can trace a person's, then use if 41% if you can trace, this says there is no community spread, because minimum 60 to 70% of the population should say, I don't know from where the source is. But for all scientific purposes, community spread means even one case where you don't know the source. Because in a community spread, everything changes from the government to the doctor. You reduce the mortality. When you are in a community spread, who cares for number of cases? Who cares? In India, who cares? 10 lakhs, 20 lakhs, 30 lakhs, 40 lakhs, nobody cares. Only cares is number of deaths. We must prevent number of deaths. So in Delhi, everywhere now we have to talk of, when you focus on death, it is community spread. When you focus on numbers, it is a non-community spread.
Thank you. With that, we come to the end of the questions, at least that came in the chat. I hand you back to the chair, Professor Joe, to kindly conclude the session and hand it back to Dr. Russell for his final comments. Over to you, Professor Joe. Thank you.
Okay, well, thank you. And thank you again, Dr. Agarwal, for an outstanding, informative, and stimulating presentation. It'll lead to many more discussions to come and have more people engaged, and we're very appreciative. I'll turn it over to Russell now for conclusion.
Okay, thank you, Dr. KK Agarwal. Dr. KK is also part of our UNESCO program, and when he was the IMA secretary and president, he brought this in. He was there in Cyprus, Dr. Joe. He was at our conference. He was there. So thank you, Dr. KK. I know that you've got another program, and thank you for giving us a wonderful, or at least all from all over the world. We have from South America, North America, all over Europe and Asia and so forth. So we've given all a good expose of COVID, which, as you said, it keeps changing. What we knew a few weeks ago, you've now brought. It seems to be changing. The parameters are changing. Everything is changing. So this has been wonderful, and again bringing the ethical aspect, which I thought. I know that you you gave a lot of information on COVID, the current understanding of COVID, but then marrying in the ethical aspects and the vaccine, I think has been very informative. Thank you so much for that. I want to thank Dr. Professor Joe Thornton from Florida's unit and part of one of the committee here for his chairing the session. I know it was 7 in the morning in Florida when he joined us. So thank you so much for that. And Dr. Mary, who is our co-chair, thank you. And Derek, thank you very much for that, for your moderating, following up the chat boxes. And a great thanks to all our participants who have been coming. This is the 17th, and Dr. KK Agarwal has been on this program a couple of times before as a panelist in other areas, but I'm glad we got you to bring this part. So we'll end this now. Just to tell you that we continue. The next week will be with the looking at the ethical issues that the nursing professionals are going to meet us to tell us about, to discuss this issue. And we'll be having the nurses from Canada, United States, United Kingdom, Israel, Kenya, India, United Arab Emirates, and I think Oman and so forth. So we'll have a wonderful, again, another group of colleagues from around the world, continuing the solidarity, but bringing together their issues. So please join us for that program that will be run next Sunday. So thank you all for your attendance here, and we continue with our programs and we continue with our solidarity. So stay safe and stay well, and we'll see you all again. Thank you.